knew already. Access to dental care for low-income children is inadequate. With the recent increase in the number of children eligible for benefits, access to dental care will certainly get much worse without an immediate fix. Last week, I convened a joint legislative audit hearing on the lack of access to justice. Here we are today talking about the lack of access to dental care for low-income children, our most vulnerable. The pattern is disturbing and unacceptable. The auditor documented significant problems. Most disturbing is that in 2013, more than half of the 5.1 million children enrolled in the program did not receive dental care. Low utilization, low reimbursement rates, low provider participation. This is a formula for deficient and ineffective programs. This leaves low-income children at a much higher risk for dental disease that is preventable. Simply not acceptable. The state auditor and her staff will describe the deficiency at the Department of Health Care Services that contribute to the lack of access to dental care. We will hear from a panel of stakeholders who will give firsthand experience. Finally, we will hear from the Department of Health Services. I will keep my comments very brief to allow, my Vice Chair, Senator Roth, to have opening comments, after which we'll have opening comments by the Chair of Health on the Assembly side, Mr. Bonta, and then we'll have comments by Senator Hernandez, the Chair of the Senate Health. Senator Roth.
Mr. Chair, I defer to the Health Committees.
Sure. Thank you very much. Mr. Bonta, for opening comments.
Thank you, Mr. Chairman. I'm honored to be here today. Thank you all for being here, all of the stakeholders, witnesses, participants in today's very important discussion. Thank you to all my colleagues that are here and will be joining us as the hearing proceeds. Rob Bonta, honored to be the chair of the Assembly Health Committee, and I think we all can agree that protecting the basic health care needs of our children should be a top priority for our state, and also that the findings of the audit that we are all here to discuss today are alarming. Over half of California children enrolled in Medi-Cal did not receive dental care through the program. 27 counties have no or an inadequate number of providers. This is completely unacceptable. Last year, the legislature restored dental services for adults on Medi-Cal. Today, 1 in 3 Californians are on Medi-Cal and therefore eligible for services through the DentaCal program. The audit clearly shows that we are not prepared to provide the dental care that Californians require and deserve. I look forward to the discussion here today and to working with the department and all stakeholders to find solutions we can implement this year that will correct these problems going forward and ensure that our children are provided with the high-quality dental care they deserve. Thank you.
Thank you very much. Senator Hernandez.
Well, first of all, I'd like to thank the prospective chairs from the Assembly Health as well as Assemblymember Gibson for putting this hearing together. I definitely have some concerns, and I think the concerns I have from the state auditor is the utilization, or shall I say the poor utilization that children in the DentaCal program have used or have been utilizing these services. And we all know the importance of dental care, especially amongst children. It's not only oral health, but it's overall health of the child and how it affects, their performance, whether it's in school or just in life in general. And so there's a lot of questions. I think the questions that have to be posed are, number one, are there enough providers? The distribution of the providers, but more importantly, and perhaps, is it the reimbursement rates of the providers? The other questions that we have to be asked is the type of care that's being provided to them. At one point, if you look at whether it's managed care, whether it's fee-for-service, and what's the best model that would fit for this particular population, and how we're going to be able to provide that service to those very needy individuals in the state of California. So I'm definitely looking forward to hearing the testimony from the various presenters and, of course, from the response from the Department of Healthcare Services, and to find out what we're going to do to resolve this problem. But otherwise, I'd like to thank the prospective chairs for allowing me to make a few comments.
Thank you very much, Senator. I want to take the opportunity to invite my colleagues to also have opening comments. We'll start on my left. Ms. Waldron, would you like to have Mr. Woods?
Yes, thank you, Mr. Chair, and other chairs and panelists and participants here. Being here today to discuss the State Auditor's report on the Denti-Cal program. I read this not once but twice. I guess I was hoping for a better ending the second time, but it didn't work out that way. I was looking for a pretty strong word to describe the audit, and the only thing really that came to mind was the word scathing. The report calls into question many things. At the end of the State Auditor's report, there are 22 separate recommendations made, and DHCS agrees to 21 of them. The one that they don't agree to, which is to include a provider-to-benefit ratio in the October 15th report, 2015 report to the legislature, is because they don't believe it's required by law. People on this dais could change that if it pleases the department, but we shouldn't have to. I also find it fascinating, amusing, and somewhat dismissive that DHCS largely agrees, quote here, largely agrees with the overall recommendation, but the report does not appropriately represent the facts and programmatic health of the California Medi-Cal dental program. I'll be really interested to hear how DHCS categorizes the health of this program. In the 5 counties I represent, a total of 12 providers are willing to accept new children under this program. That's a ratio of 1 provider to 3,000 beneficiaries. Now, not everybody who practices has 100% of their practice in Medi-Cal. As a matter of fact, the healthy population for a practice is considered around 2,000 patients per provider, not 3,000 Medi-Cal beneficiaries, a very, very different number. In 1 county, there are no providers willing to accept patients. In 3 of the counties that I represent, only 1 provider is willing to accept new patients. And in Sonoma County, the most popular of the 5 counties I represent, only 9 are willing to accept new children as beneficiaries. As I noted in the joint hearing, I'm listed on the DHCS website as a provider. I checked it again. I'm still listed. I'm not practicing. I haven't been practicing for about a year and a half. I'm still listed as a provider, though. We can take a look at a lot of the issues that are leading to low participation, and many will rightfully point very directly at poor reimbursement rates, less than 35% of the national average. But there are many other issues pointed out in that report, like, for example, a 22-page paper form to apply to be a Medi-Cal provider with an additional 5-page form specific to dentists. And quite honestly, the most cumbersome billing system in the California marketplace. I could offer many more. It appears that the increased shift to managed care, with the increased shift, the administration is moving to eventually completely delegate responsibility for care to third parties under the supervision of DHCS. However, their oversight of the current plan administrator, Delta Dental, has been inadequate. The CSA reports that 3 of 8 provisions of the contract with Delta are not being met, and one is of great concern to me: the development of plans to remedy dental access in underserved areas. Further, it appears that DHCS has failed to monitor the Denti-Cal program adequately as required by law. They didn't review their rates annually from 2001 to 2011 because they thought someone else was doing it. I'm stunned by that. Their actions for improving beneficiaries' utilization and participation are ineffective, and they don't collect sufficient data to fully comply with federal and state reporting requirements. As noted on page 1 of the report, the very first page, quote, "Tooth decay in children can cause significant pain and loss of school days. It can lead to infections and even death." Do we really need a repeat of the Diamante driver death in Maryland in 2007 when a 12-year-old boy died of a dental infection to get these things fixed up? I sincerely hope not. I hope we're not planning to continue to send a message to California that California does not care about its poor and most vulnerable, and that significant, measurable improvements in this program come very soon. Thank you, Mr. Chair.
Thank you for your comments. Any other members care to make any opening?
Real quickly, I would just like to say it's a great honor to be part of this body and address this issue. My father was a dentist prior to his passing, and Dr. Wood's remarks are greatly appreciated. The one thing I will say that it's often forgotten that dental health affects the overall health of a person's entire health picture, and that prevention is so powerful in addressing a lot of the circumstances that a lot of our population are going to experience if we just had some intervention. And that's our responsibility, to make sure a delivery system is real, it's workable, and that the most vulnerable of our population gets served.
Any other members? Yes, sir.
Thank you. I want to thank the chairs for calling this meeting together. While I am not a dentist like my colleague, Dr. Wood, nor am I a doctor, but I played one on TV, I am very interested in this issue. We have had very robust conversations about Denti-Cal issues in the Health and Human Services Budget Subcommittee, and we'll continue to do that. The facts are very clear. When 56% of the kids who are qualified and eligible for the program haven't seen a dentist, we've got a major problem on our hands. And so my hope with this group is that our time spent on fact-finding will be mostly on what are we going to do about it. The facts are very clear, and I think it's time for us to move action. I know that there are representatives from the department who have some strategies for how to move this forward. We want to urge them to move swiftly and to consider many strategies, both short-term and long-term. Some years ago, when I was in local government, we actually built a state-of-the-art dental clinic in one of our elementary schools. It had one of the highest rates of poverty and Medi-Cal usage, because we found, as Dr. Wood pointed out, that when children are in pain, they cannot learn. And so we know that the impacts are many on health, on well-being, on education, and on many other bottom lines. So I'm thankful for this joint committee's work and looking forward to your recommendations, and know that the subcommittee on Health and Human Services looks forward to working with you on how we move this conversation forward. Thank you.
Thank you, sir. Any other members? Dr. Pan.
Thank you, and I want to thank the Joint Legislative Audit Committee and, of course, both the Assembly and Senate Committees on Health. I'm a pediatrician, and when I first came to California, Sacramento, UC Davis, I was actually astonished at the difficulty my patients, many of whom are Medi-Cal, had in trying to get dental care. So this is going back to 1998. And in fact, struggled with this and with my colleagues as we were seeing these children come to us who were taking care of them at our pediatric clinic, and the challenges they had with getting dental care. And when I first got into the Assembly, actually the first 5 commission in Sacramento County did a report. They looked just at Sacramento County's geographic managed care system and noted the low utilization rate and also the lack of oversight by DHCS over the Denti-Cal program. And in fact, know that former Senator Steinberg, my predecessor, worked hard on that issue. But one would hope that would have already been a warning shot to DHCS that they had some problems in their Denti-Cal system. In fact, one of the most shocking things in the report was to note that when they were trying to review data from the various dental plans for that report, there was an entire dental plan that didn't even submit data, and the department didn't even notice that the data wasn't there until the people who were doing the report said, so where's the data on this plan? And the department didn't even notice it was missing. And so, I think that's quite troubling in the oversight. And then, yet, despite that and all the actions that took place, we now have this auditor's report. And I appreciate what Dr. Wood said. How did the department not know, if they thought someone was doing it, this review of the access? Clearly, they didn't care about the results, because otherwise they would have known they didn't have any results to look at. It's not just a matter of doing the report. It's actually a matter of looking at the results that should have mattered. And even if, quote, someone else was supposed to be doing it, someone didn't care enough to say, well, we actually care about the results, to realize they didn't have any results to follow up with. And so certainly I hope the department will address that issue as well. This is important. Dental caries is the most common chronic disease in children. Beyond asthma, beyond a lot of things that I take care of, dental caries is the most common disease. And we've heard from other members the tremendous impact it can have on their education, on their health, And so we need to fix this. And so, certainly I'm looking forward to hearing the discussion, but in the end, this has to be more than just talk. I appreciate what the auditor's done to look into these issues. Now it's time to act. And I hope the department will be talking about what kind of actions they're taking, including actions necessary to ensure access, whether it involves reducing the bureaucracy, increasing rates, whatever else. We cannot tolerate this continue. This has been going on at least since 1998. We cannot let this continue for another year. Thank you.
Thank you, Dr. Pan. Any other member comments? Seeing none, now for a presentation on the audit of the Medi-Cal dental program, our California State Auditor, Ms. Elaine Howell. Thank you, ma'am, for joining us. Sir, if you would identify yourself for the record.
I'm Dale Carlson. I'm with the California State Auditor's Office. I was the team leader for the audit under discussion today.
Well, thank you for joining us. Madam Auditor.
Thank you, Mr. Chair and members. For the record, my name is Elaine Howell, California State Auditor. We're briefly, and Dale, Mr. Carlson will do a fair amount of the presentation today. We're hopefully going to go through a high-level overview of the key issues that we identified in the audit report. We have a few figures. All of this information is in your binders. But basically what I'd like to do is just give you high-level results, and then Mr. Carlson will step you through each of those key issue areas that we identified. As was indicated, we were asked by the Joint Legislative Audit Committee last year to conduct an audit of Medi-Cal dental program in California, specifically looking at access to dental care for children. We issued the report in December of 2014. Three key issues that we will discuss today. Three components: beneficiary utilization, as many of the opening comments have talked about that. Utilization rates for children are very low. Provider participation. Many counties lack a number of sufficient providers or lack any active providers at all. We will be discussing that as well. And then finally, the third issue is related to reimbursement rates paid to providers for Medi-Cal dental services. As was indicated by Dr. Wood, the last time the rates were increased was back in fiscal year 2000-2001, and the Department of Health Care Services is not annually assessing those rates and making sure that those rates are adequate for the providers, to get more providers to participate in the program so that there is access for children so we can get the utilization rates up. Those are the three key components that Mr. Carlson will be stepping through. Again, we have a few graphics that tie to some of these issues, and we'll present those as Mr. Carlson moves through the three key issues. So I'll hand it off to Mr. Carlson.
Thank you. Good afternoon. Chairs and members of the committees. As I said, I'm Dale Carlson. I was the team leader, the supervisor for this audit. I'm going to dive right into the specifics about the three issues, and then I have a couple of other issues I'd like to bring to your attention. Regarding beneficiary utilization, we concluded that children's use of Medi-Cal dental services in California was low. Utilization is the annual rate at which Medi-Cal beneficiaries aged 0 through 20 received at least one dental service. We took a look at this using two different sets of data. Using national data, we calculated that California's utilization rate was 44%, comparing that using the same data to a national rate of 48%. Even though there was only a 4 percentage point difference, California was the 12th worst amongst the 49 states and Washington, D.C. included in that data. The utilization rates for other states range from a low of 24% in Ohio to a high of 63% in Texas. We also took a look at the Department of Health Care Services' own data and calculated a utilization rate from that information. We calculated that California's utilization rate in 2013 was 41%. We also calculated utilization rates for each of California's 58 counties. For 2013, the rates ranged from a low of about 6% in Alpine County to a high of 53% in Monterey County. To understand the factors that contributed to low utilization, we reviewed numerous published studies on the issue. The studies cited several reasons for low utilization rates, including the relatively small number of dentists participating in Medicaid and the uneven distribution of those dentists geographically. Regarding provider participation, we concluded that many California counties may lack a sufficient number of dental providers. We looked at provider participation in two ways. First, the number of providers who actually rendered a Medi-Cal dental service in the past year. We called those active providers. We also looked at the number of providers willing to provide dental services to new Medi-Cal patients, which we called willing providers. To compare the number of participating dentists, we used a ratio of one dental provider for every 2,000 child beneficiaries as a benchmark. We used this ratio because healthcare services had used this ratio to monitor the transition of children from the Healthy Families Program into Medi-Cal during 2013. Further, state regulations require the ratio for healthcare service plans. When calculating this ratio on a statewide basis, we found for the 5 years we looked at, California's ratio never was more than 1 to 807, which is well below the 2,000 ratio, the 1 in 2,000 ratio, keeping in mind that the lower the ratio, the better off things are. But because beneficiaries and providers are not uniformly distributed around the state, we calculated the ratio for California's 58 counties.
You have to do it over there.
Oh.
There we go.
Regarding counties, healthcare services data showed that 5 counties may not have any active Medi-Cal providers for child beneficiaries in 2013. Those are the 5 counties shaded on the map on the screen. Concerning willing providers, the department's data show that 27 of the state's 58 counties either did not have any Medi-Cal providers or may not have enough dental providers willing to accept new patients. The department's data show that these 27 counties had about 468,000 Medi-Cal beneficiaries who did not receive dental services in 2013. Looking again to published studies, they identified several reasons for providers not participating in Medicaid. One reason we examined was low reimbursement rates. We compared California's reimbursement rates for fee-for-service dental to national and regional averages and also to the rates for other states. When looking at the top 10 procedures most frequently authorized for payment, the averages were, for California, it was $22. The national average was $62. And the average for the Pacific region, which covers the 5 western states, was $70. In looking at the Medicaid rates for other states, we found that their rates ranged from a low of $28 for Washington to a high of $53 in Connecticut. We chose these 3 states, Connecticut, Texas, and Washington, because their utilization rates were amongst the top 5 mentioned in a June 2013 report that we examined. Officials from these 3 states confirmed for us that they believed that their reimbursement rates were one of the factors leading to their state's high utilization rates. Further, Connecticut told us that its reimbursement rates had last been updated in 2008 in accordance with a class action settlement. Similarly, Texas stated it increased its reimbursement rates for selected commonly used dental procedures in 2008 as a result of a lawsuit. California's reimbursement rates for dental services were last increased in fiscal year 2000-2001. Further, California reduced reimbursement payments for dental services by 10% for most providers effective September 2013. Essentially the same thing as a 10% cut in the reimbursement rates. Because of difficult economic times, California, through AB 97, reduced healthcare required healthcare services to reduce by 10% its payment for most Medi-Cal fee-for-service benefits, including dental. In October 2011, the U.S. Department of Health and Human Services approved California's application to reduce the rates. Several parties challenged the reimbursement rates in court, claiming that healthcare services reductions did not comply with federal law. Although the court did not decide whether California's rates were reasonable, the courts did conclude that Health and Human Services review and approval of healthcare services state plan amendment implementing the rate reductions was reasonable, and the U.S. Supreme Court declined to hear the case. Healthcare Services then subsequently implemented the 10% reduction in September of 2013. As was mentioned previously, we examined Healthcare Services compliance with a state law to annually assess reimbursement rates and found it was not doing so. State law requires this annual rate review to ensure that Medi-Cal beneficiaries have reasonable access to dental services. Healthcare Services, since fiscal year 2000-2001, has performed this review only twice, once in 2011 and once in 2013. The acting division chief for Healthcare Services told us regarding this review the department had not performed the reviews before 2011 because of the state's fiscal climate and its own workload. He also stated until 2011 he was unaware of the provision of law and that Healthcare Services performed the 2011 and 2013 reviews only at the request of the department's legal counsel. He finally stated that Healthcare Services has not finalized a plan to perform these reviews in the future. Moving on to another issue, DHCS has not complied with its plan for monitoring Medi-Cal child beneficiaries' access to dental services. As part of the 10% rate reduction, Healthcare Services agreed to implement a monitoring plan. 3 of the measures in that monitoring plan relate to dental services. As of October 2014, Healthcare Services had not issued its first monitoring report, and DHCS did not give us a specific release date for that report at the time of the audit. And lastly, Healthcare Services authorized reimbursements for providers who purportedly rendered services to deceased beneficiaries. We analyzed Healthcare Services data and found that it had reimbursed providers for services rendered to 153 beneficiaries who, according to Social Security Administration records, had passed based on their Social Security numbers. Our analysis of the data indicated that the reimbursements totaled more than $70,000 for procedures that were purportedly provided between 2009 and 2013. We identified a similar issue in a report we issued last August on drug Medi-Cal. The fact that we found the problem in a second Medi-Cal program supports our conclusion that the issue could have even greater implications related to Healthcare Services and other Medi-Cal programs that also rely on the system's data. As was mentioned earlier, we made several recommendations, just differences in the way we count. We count 24 recommendations. Of the 24 recommendations, Healthcare Services agreed with 23. It has implemented one of the recommendations. Part of what we do as a matter of practice is ask the departments, the auditees, to respond back to us at specific times after we issue an audit report. We have the department's first response, its 60-day response. Of the remaining 22 recommendations based on that 60-day response, Healthcare Services believes that 15% will be implemented by July of 2015, 7 months after our audit report. 2 should be implemented by July of 2016, and 5 currently show no implementation dates and are listed as either pending or ongoing. Ms. Howell and I will be happy to take any questions you might have.
Let me just ask the first one, if I may. Do you have any idea what level of reimbursement rate increase would be necessary in order to drive an increase in the number of providers available to provide these dental services?
Senator Roth, we didn't do that type of analysis. What we tried to do, as Mr. Carlson indicated, is compare utilization rates in other states to California and then tying that to reimbursement rates as one of the driving factors, certainly in provider participation, which again provides additional access. We do not have a specific number as to what the increase, if there is one, should be.
Okay. Member questions? Dr. Pan.
Thank you.
So, first of all, you had mentioned that in violation of state law, that the Department of Healthcare Services only performed 2 out of 10 assessments of provider access. Have you had a chance to look at those 2 reports and part of your audit? And how did they comport with the findings you did in your audit? I mean, how extensive were those 2 that they should have done 10? And I mean, how extensive were they? And did the department actually make any change in actions as a result of the findings from their own reports?
Yeah, we did take a look at both the reports. In the December 2011 report, the department did not include a recommendation about the adequacy of the rates and access. In the 2013 report, based on information that they had put together looking at both utilization rates and at provider participation rates, the department concluded that rates were sufficient. One of the things that they had included as part of that, in terms of talking about utilization, they had pointed to an overall increase in utilization from 9-10 to 10-11 of about 1.6 percentage points. And they also pointed to an increase of about 88,000 individuals who had received services between those 2 years as support for its conclusion that the current reimbursement rates were adequate.